Hello everyone, welcome back to M-Pharma Training Solution. Today I will be briefly explaining antihypertensives. Now, of course, what is hypertension? Hypertension is a chronic elevation of blood pressure, and of course, know that blood pressure is a product of cardiac output and systemic vascular resistance. Now, of course, we know that arterial hypertension is as a result of increased cardiac output, increase in systemic vascular resistance, or both. And of course, this one is coupled with increased adrenoceptor stimulation. That's why we have the beta blockers, and again is increased values of the peptides such as angiotensin 2. Now, of course, we know that before we can talk about antihypertensive, we have to first explain what is the renin-angiotensin system. The macula densa located in the adjacent to the juxtaglomerular cells is composed of specialized cells, and that detect changes, of course, in sodium reabsorption and transmit impulses to the juxtaglomerular body that modify renin release. Also, on the juxtaglomerular cells, we have beta-1 receptors, and of course, these beta-1 receptors can increase cyclic AMP and also enhance renin secretion. Because when we reach on the beta blockers, we are going to talk about them inhibiting renin secretion through this process. Now, of course, what is renin now? Renin enzyme acts upon angiotensinogen to angiotensin 1. Of course, angiotensin 1 is then converted by endothelial angiotensin converting enzyme SCE to arterial vasoconstrictor angiotensin 2. This is the potent vasoconstrictor, and also angiotensin 2 stimulate vasopressin release. Of course, you know what vasopressin is. It is the ADH, antidiuretic hormone, and of course aldosterone, as explained earlier in our aldosterone also enhances sodium reabsorption through the sodium reabsorption through the coveted tubules, and it also causes cellular hypertrophy. And then other mechanisms in hypertension, which other system which you have to know is the kallikrein-kinin system. Now, the tissue kallikreins act on kininogen to form vasoactive vasopeptides such as the vasodilator bradykinin. Now, SCE inhibitors decrease the breakdown of bradykinin, hence we shall have vasodilation. We also increase blood volume and also arterionatriuretic peptides, which take part in hypertension. Now, let us first explain the risk factors of hypertension, because this one form a basis for non-pharmacological management of hypertension. And when you're dispensing any antihypertensive, it is always important to explain to the patient the non-pharmacological management. Now, which are those risk factors? We have age, of course, age, or overweight and obese, physical inactivity, someone who has a sedentary lifestyle, excessive salt intake. Of course, you know what happens when you have excessive salt intake. We shall retain more of the fluids in the body. Excessive alcohol intake, stress is very important, diabetes, and the chronic kidney disease. Of course, why chronic kidney disease? We have seen above, the macula densa is indicated in the kidney and the juxtaglomerular complex. Let us talk about the antihypertensives. However, I'll first explain briefly the diuretics. Before I explain the diuretics, I first talk about these terms. Of course, we know a diuretic is an agent that increases urine volume. Natriuretic, an agent that increases renal sodium excretion. Aquaretic is an agent that increases excretion of salt-free water. Now, of course, we know that the functional units of the kidneys are the nephrons. I didn't want to go through the parts of the nephron because I'm sure you're aware of them. This is a short presentation. And of course, urine formation is through the mechanisms. I'm sure you can explain them: glomerular filtration, tubular reabsorption, and tubular secretion. Now, the examples of diuretics which we have osmotic diuretic, These are freely filtered by glomerulus. Example, we have mannitol, and they prevent the normal absorption of water by interposing a counter osmotic force. Because they are osmotic, they instead of water being reabsorbed from the renal tubules, it again remains within the renal tubules, hence it is excreted. And of course, they are used in brain edema, and very many other examples, or in head injury and head injury. Little reach there and head injury. Now the other diuretics have carbonic anhydrase inhibitors. They inhibit the carbonic anhydrase enzyme in the proximal convoluted tubule. I'm sure you are aware what happens when we inhibit this enzyme. Now the examples include acetazolamide and methazolamide. This one, of course, they are used in glaucoma and in prevention of mountain sicknesses. I'm sure you have very many examples. Side effects, briefly, we have renal stones and acidosis. The potassium sparing diuretics, they prevent, of course, potassium secretion by antagonizing the effects of aldosterone in the collecting tubules. Examples, we have spironolactone, eplenolone, amilolide, and triamcinolone. Now, these ones are commonly used in combination with other antihypertensives. I'm sure you are aware of the side effects of these drugs. Remember, I'm going to go through the side effects because I'm sure you have those ones, and with this presentation you can go and then get them. Because if I'm talking about the side effect, the presentation will be long, which I didn't want it to be. The thiazide diuretics, they inhibit the sodium chloride transporter in the distal convoluted tubule. This one. And of course, examples, we have hydrochlorothiazide. This is common in combination. We have the benzofluorothiazide, the chlorothiazide used, of course, in hypertension and then of heart failure. Side effects of hypokalemia, weakness. We can also have allergic, because they have a sulfur in it, thia. They have a sulfur component. Some patients may be allergic to them. Now, the loop diuretics, we have these, of course, they act in the first this one. They act in the thick ascending limb of the loop of Henry by inhibiting the sodium potassium chloride transporter. Of course, examples include furosemide, tosemide, and butamide. These ones are used in hypertension, of course, severe hypertension, cardiac congestive heart failure, and then, of course, in renal failure. Side effects of hypokalemia, skin rash, and hyperuricemia. Now, this is where now the potassium sparing come in, used in combination